Next is about the fistula in ano. Now, fistula in ano, by definition, is an abnormal hollow tract or cavity that's lying with a granulation tissue and that connects a primary opening inside the anal canal to a secondary opening in the perianal skin. Secondary tracts may be multiple and can extend from the same primary opening. It should be differentiated from the following processes which do not communicate with the anal canal, like hydradenitis suppurativa, infected cysts, pulmonary sinus, Bartholin gland abscess in females. Now the point is, to define a condition as a fistula in ano, there should be a connection with the anal canal and there should be a tract with the granulation tissue, abnormal granulation tissue. Now, if you refer to Sushruta and then the differentiation between Bhagandari Pidaka and Abhagandari Pidaka, Payosya Benguladesha Gudamula Sarvjara, that the relationship between the Payu, that's the anus, and the abscess or the swelling is very well defined in Sushruta, and that's again a very mature definition of the fistula in conditions. And when a patient comes to you with a pus discharge in the perineal area, you have to confirm like whether there is a definite tract or not. If there is no definite tract and which is involving the anal canal, then we will not consider this as a fistula in ano. That's the important thing. Then there could be the other causes and which are beyond the discussion point as such. The symptoms of fistula in ano, of course, almost every fistula in ano is a consequence of the abscess, perianal abscess or ichthyorectal abscess. The abscess conditions which we have discussed in the previous session. Any of that if it is not treated properly, or maybe even after sufficient treatment, there could be situations where there could be granulation tissue left over or the pus will be retained in, which can result in the fistula as such. Clinical symptoms of fistula in ano are mainly, the most important is the perianal discharge, and discharge which may not be related to the act of defecation. There could be a continuous discharge. Many times the discharge could be purulent or many times it could be even fecal material. If there is a presence of fecal material in the discharge, that confirms the anal connection. But that's a presence of fecal material is not must to confirm the diagnosis. So even if it is the other way, either purulent or seropurulent discharge could also be evidence of the fistula in ano. But the most important is that the tract has to be confirmed. The other symptoms which could be presented are pain, of course naturally, pain which again would be more when there is a collection of the pus. Once the fistula starts draining out, the intensity of the pain reduces. So most of the times the patient would have episodes of waxing and waning of the pain. When there is a blockade and the accumulation occurs, then the patient would have more pain, and once it starts getting discharged, the pain may be reduced. As a general, pain may be even aggravated during movements or maybe sitting, like when there is more pressure on the area, that also can reduce the pain. Swelling in the area also could be the clinical symptom, particularly when there is a collection, when there is a blockade and then the discharges get accumulated, it can even present with swelling. Bleeding also can be the symptom. Occasionally, patients may have an abnormality of the bowel movements, either it could be diarrhea or simply because of the irritation of the anus, patient may have even incontinence of the stools. So diarrhea or incontinence also can occur in case of fistula in ano, or simply difficulty in defecation because of the pain. Skin excoriation, continuous discharge of these contents can produce irritation of the skin, and there could be either the destruction of the keratin tissue and then the skin may become soft and inflamed, or there could be multiple eruptions over the area. Openings, external openings also are the one of the common clinical signs. But some of the patients of fistula may present without the external opening. There could be an internal opening alone, and number of external openings also can vary. It could be one or it could be many, and whenever there are multiple external openings, the important is to confirm whether there is a tract or not. And the most dependable confirmation of the diagnosis of fistula in ano by the two-finger digital examination. That's important. Whenever you are suspecting a fistula, it's not enough if you put a finger into the anus. Along with that finger in the anus, the other finger you have to hold the edge of the anus and then try to rotate the finger so that if there is any induration and tract, that can be better felt. So finger digital examination method is a very standard benchmark method of confirmation of the fistulae, and the tracts also, location of the tracts can be confirmed by that. So this method has to be followed, and I would always say that the two finger digital examination is much more efficient and more specific than any other sophisticated investigations to make out. Usually whenever there are external openings, to locate the internal opening and to identify the tract easily, we follow a general rule, and that rule is called as a Good-Salt's law. That Good-Salt's law says that if there is a external opening on the anterior half of the anal margin, anterior side, then the tract could be straight, and if it is within 2 inches from the anal opening, then the tract could be straight. This is because of the pattern of the lymph nodes, lymphatic circulation. But if the tract opening is on the posterior half, the internal opening is always in midline, and hence the tract could be curved. So, and of course, if the external opening is beyond 2 inches from the anal margin, then even it could be connected to the posterior lymphatic circulation, and hence the internal opening could be in the midline. So most of the times in the posterior lesions, the midline, the internal opening will be in the midline, external opening could be anywhere, and naturally that results in a curved tract. When the tract is on the external opening is on the anterior side, the internal opening will be on the same direction, and hence most of the times the tract will be straight, and this is exactly what's called as a Good-Salt's law. But there are many exceptions. It's not that the Good-Salt's law is mandatorily correct in all conditions. There could be a few exceptions, and hence a thorough clinical examination is most important. The fistulae in ano are classified in different manners. Like the most popular method of classification is a Parkes classification system, and it's based upon the direction of the tract, the location of the tract. Either it could be intersphincteric, which is found between the internal and the external sphincters, as you see over here. The tract would be in between the sphincters, and this classification also has a role to play with the management and maybe the consequences, complications even. And majority of the patients whom you see now are of intersphincteric variety, where the tract would be present between the sphincters as such. Then transsphincteric is across the sphincter, that external as well as internal sphincter is crossed through. Particularly the external sphincter is crossed through. When the external sphincter is crossed through, in such conditions, the consequences would be more. There is a possibility of incontinence in the later period after the treatment, and hence that has to be carefully handled. And these constitutes around 90% of, more than 90% of the total variety of the fistulae we see, intersphincteric and transsphincteric. Then the other less common varieties are extrasphincteric, where the tract is beyond the sphincter, outside the sphincter, but crosses the sphincter at a very high level, and there could be an extension into the ischiorectal fossa beyond that also, or supralevator connections also could be presented over there, and these constitute a relatively lesser number of the conditions. Important is, in that condition, the internal opening may be at any lower level, which may give you a confusion about the location of the tract, or suprasphincteric, where it even extends from the intersphincteric plane through the puborectalis, and it also can have multiple openings at above the level as such. Now, more detail about this. Intersphincteric fistula is characterized as it's usually complication of a perianal abscess, low level abscess, and it again the course will be, it begins at the dentate plane, then tracks via the internal sphincter to the intersphincteric fossa, intersphincteric phase between the internal and external anal sphincters, and terminates in the perianal skin. And most of the times there will be an involvement of the crypts, the anal crypts glands. The cryptite is the complication. Because the gland is involved, the chances of the fistula tract having a epithelial layer also are more. So it's not only the granulation tissue in intersphincteric fistulae, the epithelial surface also could be presented over the tract. Then the other maybe there could be chances of multiple tracts connected to this, and it involves maybe when there are multiple tracts, one of the tract may be very high, even reaching up to the rectum or the pelvis, which has to be very carefully seen. So typical presentation of a intersphincteric fistula, you will see the external opening over here, and the tract could be passing through the sphincters over the area. Then transphincteric, it's characterized as which is a common complication of the istiorectal fossa. A higher level abscess can result in transphincteric fistula more commonly, and it also may have very high tract with the perineal opening, or even high blind tracts, and hence in such conditions you will have to explore the possibility of branching of the tracts quite significantly. You will have an abscess cavity and then the whole area crosses. Clinically, when a patient presents with an abscess swelling, the differentiation is comparatively easier. In a case of transphincteric fistula, there could be a tract swollen which can be visible, whereas in intersphincteric fistula, you may not see that bulged tract. It's only the bulging at the opening, external opening level, which could be seen. But still, two digital examination can help in making this difference comparatively easier. Then the relative rare varieties are suprasphincteric fistula. It arises from supralevator abscess, and it passes from the internal opening at the dentate line. So the internal opening could be at the dentate line, but the tract could be very much superior above the puborectalis also, and then again curves, and the external opening could be anywhere. And very often external opening may not be seen. It may be a blind tract also, and that in that condition the internal opening may be there, external opening may not be seen, tract could be blind, which again produces more trouble in the clinical presentation as such. So the important is the internal opening may be at a lower level, but the tract would be very high, and these are the misleading conditions where you may always have some errors in the management. External opening may be seen much away from the area. Extrasphincteric fistula is again, it may arise from usually some other complications like a foreign body, or maybe a injury to the area due to surgical injuries or so on, or diseases like Crohn's disease or carcinoma also can present with the extrasphincteric fistula more commonly. And in these conditions, the external opening can be seen around the perianal skin, but the tract would be always directly moving upwards. It doesn't end up in an internal opening. So that produces more complicated issue where you may need a more these detailed investigation methods. So that's about the Parkes classification. Another popular classification based upon the clinical outcome, which is also comparatively a new classification since 2017 onwards. Earlier Parkes classification was more popular. The current classification is Gar classification, which is gaining popularity, and that's based upon the grade 1, grade 2 and grade 3 and grade 4. Grade 1 fistula in that condition is a low fistula with single branch, so which gives you a picture about the possible complications and planning of the management. Grade 2 is again a low fistula with multiple tracts, or which is either intersphincteric or transphincteric. Grade 3 is a high transphincteric fistula, where it's a transphincteric fistula, but the location is quite high, internal opening also is high, and the patient would have presented with either impaired continence or Crohn's disease or a history of previous radiation, that even with the other variety is called as grade 3. And grade 4 classification is a high transphincteric fistula with multiple tracts or abscess, which is a horseshoe shaped, horseshoe tract, like as you see the curved tracts, which may be going very high up, and these are grade 4. Grade 5 is a transphincteric or supralevator tracts with the suprasphincteric and extrasphincteric tracts. So the Garg's classification is giving you a bit more idea about the possible complications which can occur, and the clinical outcome of the fistula can be done. There is another method of terminology of the fistulae. The correct again terminology also is known as either subcutaneous, submuscular, complex or recurrent, and second stage fistula. These are the other terms. Second stage fistula are fistulae which are produced due to the other diseases like Crohn's disease or so on. And the other terminology is subcutaneous is when it's a low anal and the external opening and the internal opening are within, and the whole tract is below the dentate line, distal to the dentate line. Submuscular are intersphincteric or low transsphincteric, where it has crossed through the sphincters. Complex are when it has crossed through the sphincters at a higher level, and or multiple tracts. This also is another method of terminology. Now, any of these terminology could be used, but important is in all management of the fistula, whole course of the management of the fistula, the most important issues which you have to consider are the most important is determine the anatomy of the fistula. That's the exact tract has to be defined. To define the exact tracts, you may make use of any of the investigational tools. Digital examination is very efficient. Then the other investigational tools like ultrasonography or maybe transrectal ultrasonography or maybe the MRI scan can be used. Another simple method of confirming the tract would be injecting some dye or maybe hydrogen peroxide. See, injecting hydrogen peroxide through the external opening. It can again help in location of the internal opening by looking at the foam over there. Dye also could be injected in, and when you use a proctoscope and the leakage of point of the dye in the internal area can also help in the internal opening. These are different methods which could be used. But as I again repeat the same, the most efficient method is the two digital examination. So once you have located the tract and then confirmed the tract, then the whole purpose of the treatment would be to provide drainage. See, as long as the tract is draining out completely and there is no collection, the symptoms will be lesser and there is a fair chance that it may heal. If the granulation tissue is not fibrous, if the tract is not fibrous, simple drainage often can help in healing the tract. But if the tract is fibrous and then the healing doesn't occur, then the tract has to be removed. To remove the tract again, you may make use of any of the techniques. So when we go into the different choices of the treatment, we consider these points as such, like how to eradicate, how to provide the drainage and so on. Then the next part is about prevention of the recurrence. So you have to ensure, because the whole area is susceptible for recurrence because of the fat tissue and then possible chances of the contamination with the fecal material. Recurrence is more common and hence you need to take a step to prevent the recurrence. Then the sphincter function has to be preserved. So any intervention at that area can produce an impairment of the sphincter function and try to preserve the sphincter function. Now, when you have these multiple goals of the treatment, naturally the techniques which you use can be different, and hence for fistula tract management you have multiple options of the treatment, and the treatment options could be the popular treatment options are either fistulotomy or fistulectomy, then set-on treatment, marsupialization, glue therapy, anal flaps or radiosurgical approach, fistulotomy or fistulectomy at the time of abscess of the incision itself, at the time of the beginning itself, or intraoperative anal retractors, or and another is a Kshara Sutra, which has become quite popular. Now, what are these? Now, the fistulotomy, a removal of the fistula tract, which was rather the older one, and then rather which is also considered as an efficient method, but because it is a technique which involves the sphincters, damages to the sphincters, the possible complications of incontinence would be more, and the time taken for the healing also could be more. Chances of the recurrence also are higher. In a intersphincteric fistula, the method of fistulotomy is just make the openings at the internal sphincter area, which may not produce the same complications, which is relatively simpler. So in an intersphincteric fistula, a fistulotomy is quite efficient rather, though technically it's not very easy, but of course the complications are lesser. But only the important is you have to be very sure that there is no transsphincteric tract there. In a transsphincteric fistula, the muscle has to be divided. A external sphincter has to be divided and cut off. And because the external sphincter has to be divided, the chances of incontinence developing in the due course of time are more, and time taken for the healing also will be more, and hence it becomes less acceptable. In a transsphincteric fistula, when the level is quite high and it's not possible to, or if you low level excision of the external sphincter may not produce the same intensity or severity of the complications, but if you have to cut above, then the complications could be more. So in such a situation, a transsphincteric fistula can be managed with a set-on treatment. A thread is applied so that the thread helps in continuous drainage, and at the same time thread also can produce a continuous cutting also. Now, set-on treatment could be either as a part of the fistulotomy, or set-on treatment also could be independent. It's also called as cutting set-on. The set-on treatment is put a fiber of different type, either it could be cotton or it could be nylon or maybe at times wires, metallic wires, through the tract. So the most important part is you have to be very sure that we are through the tract exactly, and then once you have tied it, then gradually you can tighten it. So as you tighten it, there are two advantages. Set-on can help in drainage because of the continuity over the tract, and when you tighten it regularly at regular intervals, maybe once in a week or once in 2 weeks or so on, the whole tract gets cut through. So it's a sort of fistulectomy as well as fistulotomy combined together, and hence set-on also became somewhat one of the popular technique. But the problem with this set-on is the total time taken for the healing would be quite long, and if there are multiple branches, then again it will be it may not be successful as such. It may just cut the tract, but there is no healing issue. Kshara Sutra is actually a modification of the set-on treatment rather, where we apply the Kshara and then the Kshara Sutra is changed at regular intervals. And instead of tying this Kshara or tightening this set-on, the Kshara Sutra is changed. So that Kshara, its medicated property, medical property, would help in removing the debris tissue as well as it also promotes the healing. Now, the same set-on treatment as it is placed in, it could be, even if it's a huge one, even simple rubber catheter also could be used as a set-on, which helps in drainage. Then the other options of the treatment is the marsupialization, which is not very popular. Marsupialization is the whole area of the fistula tract is kept wide open. The whole tract is removed and the area is kept wide open, and it's allowed for secondary healing. Now this procedure now is not popular. Earlier it was popular. The major problem would be the whole destruction of the tissue. A huge tissue is destroyed and the complications could be quite severe. Hence the other options are tried. The other options are you close the internal opening so that there is no further drainage. To close the internal opening, a chemical, fibrin, is used, and a sealant fibrin is used, which is a glue. Through the tract, you insert the tract, this syringe, and then a glue is just injected through and just pulled through so that the whole tract remains closed. And if it remains closed, it doesn't get contaminated. That's the idea. But this also would be beneficial only in certain simple grade 1 type of the fistula. But in complex fistulae, to inject the glue in all the tracts would not be possible. And moreover, the glue may be rejected out, and the inflammation, if it is not controlled, then there could be further accumulation of pus and new branches could be formed. Hence, it also has a limitation. Now, another of the option of the treatment is instead of trying to drain out the external tracts, external component of the tracts, you close the internal opening so that there is no more contamination. So, to close the internal opening and you ensure that there is no more fecal contamination into the tract, one of the option is advancement flap technique, where you make a small U-shaped incision over the internal opening, and that flap is lifted up. Internal opening at the sphincter level is closed with a suture, and then the flap is covered with the closure as such. So with this, the contamination of the tract further can be minimized. But this treatment also is a complex treatment. Chances of recurrence also are higher. Results are not predictable, and hence this also is not very popular. But some of the cases it could be tried as such. That's one of the options. The other of the option is ligation of intersphincteric fistula tract or lift technique. This also is another of the technique, which is just an extension of the flap surgery, where instead of simply removing the flap, the internal opening is closed. A part of the internal opening and the tract on the inner side is closed, and then a flap is put in. The part of the tract is closed by a suture. But this also has a limitation because you may close the tract. So this gives a more strengthened closure of the internal side of the tract, so that there is no more contamination. So and it cannot drain down. So it's considered like the external tract, external part of the tract could be healed by itself, healing by itself. So, but this procedure also is a very complex procedure. Chances of committing errors and collateral injuries are more, and hence it's also becoming less popular. But at one stage, some people consider this as a more efficient technique. Then the same procedure, because of the inaccuracies or risks as such, the same procedure of fistulectomy lift can be done with the video assisted fistula treatment, which is also called as VAF. The procedure is the same. The only issue is in the basic lift technique, we use a mechanical probe, then visibly identify the tracts with the naked vision, and then close and remove the tract. In a video assisted technology, the whole procedure is assisted with a fiber optic tube, so that the your identification of the tract and then the whole procedure can be more accurate. But it's a very costly technological treatment. Then another of the option which is gaining popular are the fistula laser closure, or which is also called as FILAC. The laser closure, where the fiber optic tube is inserted in, and the laser rays are passed through the fistula, so that the tract is now destroyed. The fibrous tissue in the tract is destroyed, and the tract can also be closed with the laser surgery, a high-tech treatment which also has a limitation. Then comes the Kshara Sutra. Kshara Sutra now is becoming quite popular. As I said, Kshara Sutra is a popular form of the treatment, and it's now gaining popularity. Kshara Sutra is just a modification of the set-on treatment. Instead of simply putting a set-on or a simple plain thread, when you use the Kshara, it has its medical property, and it's becoming quite popular throughout globally. If you search the Google Scholar with the Kshara Sutra in fistula, the results you get is around 284 results as such. So this shows certain popularity of the same Kshara Sutra as such. That suggests about peer-reviewed studies, journals, articles which are related to the Kshara Sutra, which are presented globally. I will not go into the details as such. But if you search in the general Google, then you get 1,14,000 results in short time. The same Kshara Sutra in fistula, the lead word, which suggests about the commercial publicity of the Kshara Sutra technique also. So it's a widespread technique as such. As such, the advantages, of course, the disadvantages and advantages remain the same. The only extra advantage is that it has a medicinal property which ensures about healing, and hence the recurrence rate would be lesser. Of course, it's a specialty contribution of Ayurveda as such. The finest, rather, the last guidelines, the guidelines about the clinical practice followed by, is announced by American Society of Colon Rectal Surgery, Surgeons in 2022. It's an important issue which gives you some clarity about the whole issue, like which of the technique could be used in each conditions. I have just copied it as such without adding any word as such. The guidelines are: endorectal advancement flap procedures are recommended for patients with anal fistula. Now, this is about the American contemporary surgical views, that flap technique where the internal opening is closed, that's considered to be more safer and more efficient from the current point of view. And those who have a simple anal fistula and normal anal sphincter functions, a lay open fistulotomy may be useful. Then low anal fistula without any branches, a fistulotomy, just keep the open tract open, also is suggested as a better treatment. Then minimally invasive surgery that involves endoscopy or laser closure may be used to treat anal fistula, and this is preferred because of the technology available. The short-term healing rates have been promising. However, the long-term healing and recurrence rates remain unknown. So, with this new technology, the long-term recurrence rate is still questioned as well. Because of generally poor healing rates associated with fistula, plugs and fibrin glue, they are considered relatively ineffective treatment for the anal fistula. So, fibrin glue and such closure techniques now are becoming less popular, and the recommendation guideline is not to prefer that as a treatment. Then patients with the complex cryptoglandular fistulas, cutting set-on may be appropriate. However, the technique can lead to functional impairment. A combination of surgery and drug therapy is recommended for management of anorectal fistula associated with Crohn's disease. In the conditions like Crohn's disease-like conditions, medical treatment of the Crohn's disease along with the management of the fistula is suggested, and the current drug is infliximab and adalimumab. Both of them are immunomodulator drugs of new generation variety, which are preferred in the management of the Crohn's disease. Endorectal advancement flaps and ligation of the intersphincteric fistula tract are options for the management of anal fistula in patients with Crohn's disease. Another option in case of the Crohn's disease, along with the medical management, the advancement flap, that internal opening being closed, as well as the fistula tract being obliterated, are the options of the treatment. Draining set-ons also can be used in such conditions where the anorectal tract could be converted into a fistula. Multiple complex tracts could be converted into a single tract as such. Now, with the patients with the Crohn's disease who have refractory anorectal fistula, local treatment with the mesenchymal stem cells is considered effective and safe. However, this approach is not widely available. So, stem cell therapy also is tried. So, that's about the whole gamut of the fistula in ano and the global approach to the fistula in ano guidelines. But from all the practical clinical point of view, though Kshatrasutra is claimed as one of the superior form of the treatment, if you are not careful about identification of the tract, and if you are not careful about assessing the severity of the fistula, there could be a bad name to the practice as such. And Kshatrasutra technique requires a lot of experience and a lot of clinical equipment to confirm and have a effective outcome. So that's about fistula in brief. The next condition which we discuss will be hemorrhoids. Now, hemorrhoids are, earlier in the olden textbooks, hemorrhoids were considered as varicose veins of the anal area. But now it's known that it's not only the varicosities, rather it's a cluster of a very vascular tissue where arterioles, venules and all the arteriovenular connections, as well as the smooth muscles, that's the Treats muscle, and the connective tissue lined by the normal epithelium of the anal canal, all of them put together are the hemorrhoids. It's not only the varicose veins as such. Varicose veins could be produced as a complication of portocaval anastomosis, and they are very rare, not common, but majority of the hemorrhoids which we see are simply a mass of the vascular tissue with the muscle tissue over there. And normally, more than 50% of the people would have that kind of a mass which is quite visible, which may be identified as hemorrhoid, but they are not really symptomatic hemorrhoids. And again, a large number of population in the world would have a status, hemorrhoidal status, temporary symptomatic hemorrhoidal status, where the symptoms of hemorrhoids could occur for a transient period, but in due course of time it may subside, and hence they also are not considered as hemorrhoidal disease conditions. So we use the term hemorrhoidal status and hemorrhoidal disease conditions. Hemorrhoidal status is a temporary phenomena where the normal hemorrhoidal tissue may become slightly bulged and then it may produce the symptoms of hemorrhoid, whereas a hemorrhoid disease is a persistent condition of the same. Now, hemorrhageal bleeding is arterial, not venous. Earlier it was believed that it is venous, but now it's known that it's arterial. Now, again, to confirm what is a hemorrhage, microscopic examination of hemorrhageal tissue shows the arterioles, venules, and then the treats muscles, the muscle tissue which is presented over there, and all of them put together is considered as the hemorrhoids as such. And normally you will have that venous cushions. These are considered as venous cushions. Now, why the cushions are formed and they are more common are the typical blood supply. The blood supply of the anus is by mainly the middle rectal artery as well as the inferior rectal vein. Now, middle rectal and inferior rectal vein are connected by a plexus, and these plexus vessels do not have valves. So, it's a superior anal plexus and inferior anal plexus would occur, and there will be no valves. That the network of these vessels, because they do not have the valves, and they are more susceptible to pressure from both superior as well as inferior direction. When I say inferior direction, like sitting on a hard board or a hard surface, sitting for a long duration. Internal also, when the patient is constipated or the bowels are loaded, that can result in the same changes of the dilatation, and hence this hemorrhageal cushion, venous cushion, may become bulged, and then it may be producing the hemorrhoid conditions. As the location of these connecting veins are at the three angles of the circle, and these locations of the three angles of the circle are named as 3 o'clock, 7 o'clock, 11 o'clock. 3 o'clock is at almost perpendicular line from the midline, and 7 and 11 considering as if you have kept your watch in front of the anus, then anterior midline forms the 12, and the lower posterior midline forms the 6 o'clock, and in relation to that clock position, as these veins are located, the majority of the patients may have the lesions in this area. But it's important that it's not that every patient would have the lesions only in this area. You will have plenty of patients who have hemorrhoids which are not exactly these locations. It could be situated anywhere. So that's because of the venous cushions. The venous cushions can be seen at these three locations, as I told you in the earlier image. But important is it is seen in the classical 3, 7, 11 o'clock position. It's seen only in 19% of the patients. This is the important thing. Hemorrhoids can be presented in any other position in a large number of people. Only 19%, that 3, 7, 11 o'clock rule is true. In others it can vary, and hence that old concept like the 3, 7, 11 o'clock are mandatory is not true anymore. Now, the causes for the hemorrhoids could be, there are a lot of theories about the hemorrhoids, and I will come to that theory different next asset. But the most relevant and most practical is because of the dietary factors, like where low fiber diet, bulky stools which produces less bulky stools, and which results in a straining at defecation, and that straining increases intraanal pressure and decreases the venous return, and hence the anal cushions are dilated. That's exactly what Sushruta says about the causes of the hemorrhoids. Where there is a increased pressure. Causes of the increased pressure could be viruddha adhyashna stri prasanga utkutrasana prasthayana bega vidaranadibhi visheshaihi. When the doshas are vitiated, they produce involvement of the pradhana dhamanihi, the vessels of the anal area. They are compressed, which results in Budavali Mamsa Pravahan Janayanti. The theories about the hemorrhoids again are many, and there are some evolving theories. The very popular theories are Morgan's hydrostatic pressure and erect posture. Morgan's hydrostatic pressure theory is because of the standing erect position of the human being, the hemorrhoids would occur. And it was believed earlier that four-legged animals would not have hemorrhoids, but now it is known that it is not true. Even four-legged animals can also have hemorrhoids, though the incidence is much lesser than that of human beings. So earlier it was believed like hemorrhoids are a curse given by the god to human being for standing erect, but that statement may not be true now. But okay, all right. The point is, this is one of the theory. A erect posture could be one of the causes which can produce a hydrostatic pressure, and then the vessels may bulge and get over there. Then the dural straining at defecation will increase portal pressure. That portal pressure theory also is not universal. Of course, portal pressure, increase in the portal pressure portal hypertension can result in hemorrhoids, but it constitutes around 3 to 4% of the total hemorrhoids which we see. In majority of the other conditions, the portal pressure may be normal. So even that also has a limitation. Another theory is a postulate that impacted feces above the dentate line obstructing the hemorrhageal venous return. This is also true to a certain extent. This is true. Then vicious circle of increased anal canal pressure and hemorrhageal collapse caught by sphincter with further congestion. This is most reliable or most dependable one, where lifestyle aspects like the sphincter compression, the dysynergia of defecation, dysynergia which we have discussed earlier, where the sphincter tone could be altered, these also can be the cause for that. Now, worldwide, prevalence of symptomatic hemorrhoids is estimated around 4.4%, but hemorrhoidal status can be seen in about 45% of the people at any one stage. The bulging of the hemorrhoid, which may be a venous cushion, which may look like to be bulging when you examine, could be seen in around 60% of the people, where it may not produce any symptoms. So whenever you do a proctoscopy, whenever you see a bulging, you have to be very sure whether that has to be considered as a hemorrhoid which requires a treatment or not. A symptomatic treatment condition only requires the treatment as such. The other risk factors which are known to induce the hemorrhoids are that human is one of the theories is erect posture causes the hemorrhoids, but it's more seen in bedridden patients who are bedridden and not able to stand straight like paralyzed patients. Incidence of hemorrhoids would be more. This also is due to the vascular congestion. So it looks like paradoxical, but it's true that it can occur in patients who are bedridden and not able to stand erect. There is a familiar tendency. So, and higher socioeconomic status, this also is true. Patients who are in a higher socioeconomic status, they would be having more concentrated diet. The food substance in the rich people in general would have lesser residue, and that low residue diet can be a cause for that. Patients who have chronic diarrhea also have a high chance of fistula, these hemorrhoids as such. Malignancies also can be a cause for the hemorrhoids. Hepatic diseases, of course, in a portal hypertension, hemorrhoids tend to occur. Obesity is also another of the trigger factor. Then elevated anal resting pressure. This is about the dysynergia. Dysynergia, which we have discussed as earlier, it can result in these hemorrhoids. Spinal cord injuries. Now, again, either it could be reduced tone of the muscles or maybe the same lack of erect posture. Then rectal muscle tone being reduced, as in case of old age, it can occur. Sphincterectomy, rectal surgeries, episiotomy in females, persons who have anal intercourses, inflammatory bowel diseases like ulcerative colitis also can be related to the hemorrhoids as causative factors. Hemorrhoids are categorized into 4 categories. The more popular classification is the Gallagher grading, and that's by stage 1, where there is no protrusion of hemorrhoids yet the patient is not able to see, but the patient may be having the bleeding symptoms. Stage 2 is there is a protruding hemorrhoids, but that spontaneously reduced. Stage 3 is protruding, but it can push back manually. Stage 4 is it cannot be pushed back manually and it remains prolapsed or protruded as such. Now, I think more than, as I said earlier, total of 40% of individuals with hemorrhoids are asymptomatic. The patients, though they may have the hemorrhoids, they may not have the symptoms as such. The most common symptom would be bleeding is the most commonly reported symptom. And the occurrence of bleeding is usually associated with the defecation, and it's quite important. In a hemorrhoid, it's accompanied with the defecation. If the patient has a bleeding in between the acts of defecation, then you have to be very careful. That could be a sign of malignancy. So, one of that, when you take the history, this has to be very carefully elevated. And characteristically, the blood is red and coats on the stools at the end of defecation. Now, another frequent symptom is the sensation of tissue collapse. The patient may have that feeling like there is something collapsed over there, and itching at the area also can occur in case of the hemorrhoids. Some of the patients may have mild fecal incontinence, mucus discharge, or a sort of flueness at the area, or perianal skin irritation can be the other symptoms in case of the hemorrhoids. External hemorrhoids are something different. Now, whatever we have discussed is about the internal hemorrhoids. External hemorrhoids are characteristically associated with the pain, and they are actually inflammatory pathology in the external area, in the subcutaneous area, and this is rather subcutaneous abscess. Rather, external hemorrhoids are a sort of subcutaneous abscesses, and they may present with a typical mass which is felt over there. The same again symptoms of external and internal hemorrhoids as the same is presented in the same manner. Now, clinical examination, either simple direct examination or a anoscope could be, proctoscope could be the clinical examination, and the presentation of hemorrhoids could be at different stages. A simple hemorrhoid, a hemorrhoid with the huge congestion, massive hemorrhoid can be seen, multiple hemorrhoids, a hemorrhoid which has become thrombose, which tends to become thrombose, a hemorrhoid which may become necrose. These are the typical presentations of the internal hemorrhoids. A fourth stage hemorrhoid where it remains collapsed and it may become necrose. That black color and that tissue destruction or even ulcerations could be seen in the hemorrhoids. So hemorrhoids can present in any of these stages. Whereas an external hemorrhoid is typically seen as a bulging in the anal margin which is inflamed, and then you may have the signs of separation, or there could be a small opening even. Now, conditions which need to be differentiated from the hemorrhoids is very important, and majority of these conditions can be easily differentiated by a careful clinical examination and palpation. So, in general, uncomplicated hemorrhoids are less palpable. They are soft, and hence when you put the finger in, it may not be palpable. But if you have a mass which is palpable, then it could be a polyp or a growth, tumor. So, a thrombosed hemorrhoid, of course, may become palpable when it becomes fibrous, but still, an experienced hand can make out the difference. A polyp may have a pedunculated appearance, surface would be smooth or occasionally rough, but it may be palpable. That pediculated appearance within the anal canal could be seen as such. A sentinel tag is usually a projection of the skin, and hence this should not be confused with the hemorrhoid. Carcinoma and warts in the hemorrhoidal anal area can be presented again with the hard but less vascular irregular surface masses, and it could be of different shapes or different numbers also. Carcinoma can present with the different sorts of presentations, but some of the common presentations of the anal carcinoma would be either a fungating growth at the anal area, which again is harder in consistency and may be having fragile bleeding on touch, or in a medullary carcinoma there could be multiple openings with these elevated edges. So, majority of the differential diagnosis of hemorrhoid can be made out with the simple clinical examination as such. The other differential diagnosis of a patient with rectal pain or bleeding, the conditions which you have to consider are abscess, where there could be gradual onset of the pain and there is a tender fluctuation mass. Cancer, it's a pain, bleeding, changes in the bowel movements and weight loss, and it can be felt as ulcerated, indurated mass. Condyloma, bleeding from the anal intercourse, patient may have that history of anal intercourse, and this whole swelling will be verrucous, that it will be having irregular surface and fragile to a certain extent. Fissures, of course, there will be the pain which we have already discussed, and visible tender fissure could be seen. Fistula, there is a soiling, that's a leakage of the discharges over there and the visible opening. Then in inflammatory bowel disorders, the history would be very characteristic. Polyps, there is a painless bleeding, and proctalgia fugax is simply pain in the rectum but no bleeding as such. Proctalgia fugax is a psychological condition, so the patient may have any pain in the area but there will be no pathology there. Proctitis, there will be a painful rectum, and when you examine, you may be feeling that tenderness or even that ulceration, small superficial erosions can be seen. And rectal prolapse, the mass will be more when the patient strains, and it has to be differentiated there. Skin cat also have to be differentiated. Complications of the hemorrhoids are mainly anemia, or blood clots which can produce the thrombosis, infection, and skin tags or strangulated hemorrhoids where the whole thing can be necrosed. Management guidelines for the management of the hemorrhoids in all conditions. The most important is dietary and lifestyle modification, such as fiber diet, laxatives, hydration, and avoidance of the straining. Medication, local medications, applications, either topical or systemic medications are tried in grade 1 and grade 2, and up to grade 3, interventions like banding or sclerotherapy are used, and in the complicated conditions, excisional operations are preferred. This is the general guideline of management of the hemorrhoids, and most important is in all the conditions, dietary and lifestyle modifications are the options. There are multiple options of the treatment tried. Now, fistula treatment also has many options, and there is the difference between one and the other is not much very significant, but you have to have some idea like the different options which are available. Sclerotherapy is injecting a fibrosing substance like either mustard oil or quinoline oil or quinine, etc., into the hemorrhoid so that the vessels are blocked. So whole approach is the vessels to be blocked. But the advantages are, this is a simple OPD procedure, but it requires anesthesia, and several piles can be managed in a single conditions. But complications are more. There could be many complications like respiratory distress, even there could be hepatitis, or there could be compartment syndrome, abdominal distension can occur, pain, pus formation, or impotency, bacterial infections, thrombosis can occur. Then a rubber band ligation is another option. Rubber band ligation is a simple, quick procedure, but limited only to the internal pipes where there is no extension to the skin. So if it is not extended to the skin, it can be managed with the rubber banding. Rubber banding, you have that Barron bands rubber band applicator, where the piling mass is held through a forceps, and then you have that applicator where a rubber band is kept in, and then the rubber band is put into the neck of the area so that the whole gets thrombosed and necrosed. Again, is least painful OPD procedure, but there could be bleeding, complications, bacteria may also can occur, and sepsis also could be the other complication. Then the other is infrared coagulation, which is again somewhat popular, like people claim that each of these. It's again a bit high technology issue, where you need to have that specific instrument, the infrared coagulating instrument, but it can be done at local anesthesia, claimed to be less painful, but it has to have multiple settings. Bleeding is common, thrombosis, ulceration, recurrence also are common. Radio frequency ablation, which is again a high-tech intervention, which needs more sophisticated instrument, and where the whole purpose is same, that whole tissue is thrombosed, that hemorrhoid is thrombosed with the radio frequency. Multiple points are used there. Then cryotherapy is another of the issue. Cryotherapy, you use a minus 190 degrees centigrade cool temperature with the liquid nitrogen is applied over the area, and that produces the same, that coagulation of the vessels. The structures, hemorrhoids tend to get coagulated. But again, complications also are common. The most dependable treatment where the recurrence is lesser is a hemorrhoidectomy. Removal of the hemorrhoids is the more dependable method, and the hemorrhoidectomy could be either two forms, a closed or open. The closed is after the removal of the hemorrhoid, the whole bed of the hemorrhoid is closed with the suture. In the open, you keep it open. Keeping open helps in better recovery of the sphincter functions. Whereas a closed one, it can result in more pain as such, but it increases or reduces the healing time. Whereas external, this open one, the healing time may be more. So complications of hemorrhoidectomy mainly are bleeding, urinary retention, and incontinence. But recurrence rate is very low. Incontinence can occur if you go for a high fistula resection or high hemorrhoidal resection. A low hemorrhoidal resection doesn't result in incontinence frequently. So technique, if you follow the right technique, the hemorrhoidectomy is rather more dependable than any of the others. Then another of the high technique is the application with the transanal artery ligation, which also is a high-tech technology where you use endoscope and then artery is ligated. Again, not so common. Then stapled hemorrhoidectomy is again you need a special instrument where the hemorrhoid is just crushed by in between the two parts of the instruments, which again has high complication results as well. Then comes the Ksharakharma. Ksharakharma also is exactly a similar procedure as that of any other coagulation procedure. So instead of making use of the high energy or high tech tools, use a Kshara where the fistula is, this hemorrhoid is visualized, and then apply the Kshara, and then the whole thrombosis would occur. There will be coagulation and thrombosis. Ksharakharma also has its own limitations. It needs anesthesia, the muscle should be relaxed, sphincters have to be relaxed, and then the risk of all the complications, because the tissue is allowed to thrombose on itself, there are the chances of the other complications can occur, whereas in hemorrhoidectomy you don't have that kind of complication. People also use a Kshara Sutra ligation at the base, and that too is the same issue. By ligating the hemorrhoid, the same issue as that of the rubber band would occur. So I don't say that any one technique is superior to the other, but the most important is hemorrhoids can be better managed with the medical management like Agni, Deep and Pachana Dravyas than any of the other issues. A comparison of outcomes between different surgical techniques published by a very sophisticated or peer-reviewed journal, very popular journal, where a high level of assessment done by a large number of people. This shows there is not much of a significant advantage of any single technique over the other. So that's about the hemorrhoids. With this we conclude today, and in the next class we will discuss about the anal cancers. If there are any questions, we will try to answer and then wind up. Okay, there are no questions, so we will close it.